Giving me the opportunity to talk about my experience with my textured implant patients. My disclosures are I'm an investigator for the Motiva U.S. clinical trial. I've designed a few instruments. Aside from the clinical trial, I use exclusively Allergan implants in my practice. So textured surface implants, they could be saline. Very early on in my breast augmentation career in the 90s, I embraced the 468 textured anatomical saline implants. So my experience with textured implants, and some of these patients still come to me for follow-up, goes back quite a few years. The surfaces that we're dealing with here and the degree of texturing varies. The Allergan BioCell, the Mentor Siltex, Sientra is more of a micro-textured surface. I think the more robust the texture, the more it does the anatomical goal of grasping the tissue, but then again, that buys other potential issues. We all know about ALCL and textured devices. I'm not going to rehash what we all know, but last January, the FDA acknowledged worldwide 733 cases with 36 deaths. Fortunately, knowing how to recognize it and treat the problem, I think, has changed the course of it and made it a much more treatable and curable process. A couple years ago, we all remember the Allergan recall. That was a voluntary recall. There's been no recommendation by any body, FDA physicians that I'm aware of, to recommend routine explantation or replacement of textured devices. And patients are notified by Allergan and physicians. I think it's very important as physicians that we have notified or done the best we can to notify our patients, because let's face it, patients will hopefully keep coming to see you, but they move, and whatever address is on that tracking form is long since gone, so we're actually in a better position if you keep adequate records. And I was sending letters to patients that I did surgery on back as early as 94, 95. So that's just part of being a responsible physician. So what are the reasons patients present for a revision with textured implant or without? Most of it's irrespective of the textured devices. So for those where we're not talking about ALCL, they may no longer want their implants. Maybe they want to switch from saline to silicone, hopefully not the other direction. A size change, which is not uncommon as the body habitus changes. Occasionally a pocket change. Or maybe they now have a waterfall deformity, need a lift or a revision of a previous lift. Mechanical issues like rupture, deflation, capsule contracture is certainly a very common reason. Occasionally there are malposition or pocket issues, although most of those present by around 4 months after surgery. So these are not reasons patients are coming in for later revisions, more for early. For saline patients, rippling, and occasionally you'll see animation deformities. I see them occasionally. I haven't had a single patient that was motivated enough to have surgery for an animation deformity. It's simple enough to do, but no one seemed to want to undergo surgery for it. And benign seroma. Textured device adheres to the capsule kind of like Velcro, and sometimes an activity or something you do results in a shearing effect as the device is pulled away from the capsule, and that can result in a fluid collection. It's not uncommon. I've seen it a few times in my practice, not a lot, but it does happen, and it's something you have to be aware. A patient would present with an enlarged breast and find some fluid. Since the whole issue with ALCL, our approach is obviously a bit more aggressive in working it up than it was before. On the ALCL side, anyone with documented or suspicious for ALCL, if they have seroma, send the fluid for CD30 and ALK. If that's positive, that's not making the diagnosis of ALCL, but that's highly suspicious. You need a tissue diagnosis to really make the diagnosis. Chronic seroma, if a patient develops a seroma a second time, to me, that's a flag. It could be benign seroma, but it could be the indication that this patient either has or may be more likely to in the future develop ALCL. ALCL, the average time to develop is about 9 years, although it can be seen as early as a year and as late as, I think, 29 years. So a second seroma to me is like, okay, we've had our fun, let's get those capsules out and change the implants. A lot of patients just don't want to deal with the idea of surveillance. They just want to go on with their life and not have to think about it. And there are a few that just, out of fear, they just want them changed. So during the consultation, when a patient comes to me and we know they have textured implants and there's a revision reason for any reason, whether or not this is on the patient's mind, I do a review of the whole ALCL issue and textured implants because they need to know this. Then the next step is damage control, trying to reduce any anxieties that I've now created. But I reassure them. I say, look, the odds are you don't have it. There's, 733 cases as of last January, and there's a zillion surgeons out there and millions of patients, and I've got a patient who I put 468s in 2001, and 3 years ago she presented with a mass in her axilla. She lived out of state at the time, and she had ALCL. So it does happen. So the next issue is the capsule, what to do about this layer of scar tissue. So there are times where total capsulectomy is indicated. Someone who's got proven ALCL, obviously, that's indicated. Someone who is highly suspicious for ALCL, again, I would do a total capsulectomy. Or someone with increased risks such as recurrent seroma. And I was talking to one of my colleagues, Patty McGuire. She was telling me that she's been aware of some cases that had negative cytologies, but ultimately did have ALCL. So keep this in mind. If you have a patient who's having more than one seroma and their cytologies are negative, have this is just my personal opinion, a low index, a low threshold to remove the capsules and get the implants out. If it's surgery, I find a seroma or nodules in the capsule or anything that strikes me as abnormal, get the capsules out. Now, then there's the patient who has gone to Google University or Facebook University, or worse yet, Instagram University, and they want a capsulectomy. How do you manage that? Well, I stratify them into two categories. Case one, the capsule is thickened, and I'm sure all of you know at surgery sometimes you'll see someone who does not have a capsule contracture, at least not clinically. You get in, the capsule's a little thickened. It's not terrible, but it's not that thin onion skin stuff either. If the capsule is thickened, that's one situation. If the capsule is totally normal, that's another. And what I mean is, for a thickened capsule, and for those of you who are a little newer in your practice, maybe you haven't done too many capsulectomies, a thickened capsule technically is very simple to peel away, especially from under the muscle. From under the breast, it's a bit more adherent. It's a little tedious. The incision, you can do them through a 4-centimeter incision, but sometimes it's just easier to make the incision a little larger. It'll heal just fine, and it'll make your life easier. I do recommend an IMF approach. I've done them under periareolar, but that was under protest. It wasn't as hard as I thought, but then a capsular contracture patient, your risk for capsular contracture with a periareolar incision is up, so that's why I don't like to use the periareolar incision for this. The next issue is drains. For many, many years, I didn't drain any of my capsulectomies, and I haven't had any seromas, at least that I knew of, that were problematic. And then recently, I had a few patients. One lived out of state. I didn't want to have an issue with the seroma, so I put a drain in. A couple others, I put drains in. Just curious to see what was different in the course. And they drain a lot of fluid, and they drain a lot of fluid for a while. So I can't put it together, what's happening. I mean, these patients are no different than my non-drain patients. So my guess is the non-drain ones probably have fluid, but they're just absorbing it. So I think drains are kind of a dealer's choice. If you have a bloody capsulectomy, certainly I would recommend getting rid of the blood and putting drains in, but if you have a fairly dry procedure, at least in my experience, I think you're fine without drains. And I haven't found capsulectomy to increase the recovery either. When you're taking out the capsule, and this comment is more addressed to the younger surgeons, be very careful to stay right on the capsule. Try and take as little to no parenchyma as you can. A lot of times with the thick capsules and the capsule contractures, there'll be some atrophy of the anterior breast parenchyma. And then when that capsule is gone, and you have to counsel these patients pre-op about the risk of this, they have very thin tissue, and they may have, when the tissue envelope is more relaxed, they may have a contour deformity, a little divot here or there that you may need to correct later with a little fat graft. Doesn't happen a lot, but it is a potential risk. And the other issue is the pectoralis major muscle. Now, if I did the original surgery, I always go back and read my original op note. Did I do a dual plane 1, 2, or 3? To give me some idea about where I'm going to find the caudal edge of the pec. If it's a patient who was done elsewhere, you just got to be hyper vigilant and really look for those fibers. You don't want to take any of the pec. If you take some from a functional standpoint, it's probably not going to mean much of anything. But in a lot of these patients, as an insurance policy, I put stratus in from the caudal pec to the IMF. And you don't want to get rid of the pec because that piece, you're going to need more stratus and you're going to have more allograft tissue rather than natural tissue making up the anterior to the surface of the implant. So you really want to preserve that caudal pec as much as possible. For a thin capsule, in the majority of cases, except the ALCL situations I mentioned, it's really not indicated. The capsule's not doing anything. It's a much more technically demanding procedure, particularly when you get to the chest wall. And patients don't understand this. Taking off a thin onion skin peel off the chest wall is not only difficult, but there is an increased risk of getting a pneumothorax. So I counsel these patients about pneumothorax. I talk about risk of a chest tube, and usually at this point I've scared them enough that they rethink it. I will still be insistent, so I'll say, look, I'll do it best I can, but I'm not going to guarantee you I'm going to get all the capsule out. There is the possibility I may have to make an executive decision on the table. What do I do in those cases? I'll cauterize the tissue. Does it really do anything? I really don't know. Remember, we're taking out tissue that doesn't need to be taken out, but at least I can tell the patient I've done something to destroy the tissue, and at least that allays their fears, and it's pretty benign, and you're not going to get a pneumothorax from running your cautery over the surface of the capsule. Unilateral capsulectomy. Let's say you have a patient with a unilateral capsule contracture, and this goes for a textured implant patient or a non-textured implant patient, and may even be more significant with a textured implant patient because the adherence of the implant to the capsule provides support vertically for the implant that you don't have with a round smooth implant. So what I'm saying is you need to discuss the consequences of loss of support. The capsule is foe and it can be friend. And when it's supporting the implant, it's friend. So you have to discuss the patient that there is the possibility when you remove the capsule on the indicated side, that now you're putting the implant back in and we're going from a textured implant to a smooth implant. And now that implant may cause the breast to stretch, and now it'll look like that breast is lower than the one on the other side. I'm not saying it's going to happen all the time, but you have to have that conversation, and I've learned this the hard way. So here's a patient who has capsular contractions, one of my cases, on the left side, and she actually had a smooth implant, but it's a great case to illustrate the problem. So I did a capsulectomy, total capsulectomy on the left side, and then in the middle photo, you can see how the breast is now descended because it's going into a pocket that is not as supported as the one on the right side. So now it looks like she's got a capsular contracture on the right side. So what do? Well, you got three choices. You can do nothing. You can put in soft tissue support on the left side, which is going to be very difficult to get the result to match the right. The easiest thing to do was just remove the capsule on the right side, and you're basically creating the same problem on the other side. And in the far right, you can see we achieve symmetry again. The breasts are a little bit lower than on the pre-op on the far left, but certainly a very acceptable result and a very happy patient. This is another one of my cases. This woman with implant, but illustrates the issue of capsulectomy. She had a beautiful augmentation, and 6 months later, she started taking ginseng, which she got from China, because it gave her energy. In fact, it gave her so much energy, she doubled on the dose of ginseng. And then she called me over Christmas and told me that about a week and a half previously, overnight, her breast suddenly got very large. And I never got a call like this happening a week and a half ago. So I was a little perplexed what was going on. Maybe seroma, I don't know, overnight, it just didn't make sense. I said, come in and see me. So she came in, and she had this huge hematoma of the right breast. And I said, you didn't call me for a week and a half? She goes, no, I didn't want to bother you. Okay. So I took her to the OR, evacuated the hematoma, replaced the implant. And as you know, the capsule is very pale and avascular. Well, this capsule it looked like petechiae everywhere. There was no active bleeding because she was off the ginseng, but you can see she was oozing diffusely from the capsular surface. And unfortunately, the damage was already done because then she developed a capsule contracture a couple months later, and then I did a total capsulectomy, and that's all I had to do and restored her symmetry. Anterior capsulectomy is a nice adjunct that I use when transitioning from an anatomic textured implant to a round implant. You can use it as a standalone procedure or perform it with capsulotomies to increase pocket size. It's just a way to move the pocket and get the breast envelope to recontour a little better as you change the shape of the implant. It's not always needed. It's super simple and quick to do. What you do is basically you're moving the capsule from the caudal pec to the fold, and I do the entire elevation with the implant in place. It takes 2 to 3 minutes. There's no indication that I can think of to do this as a unilateral procedure. I just do this if I'm switching from teardrop to round implants. Photographic documentation, very, very important in these cases. You want to take photos of the implants, take them front and back, and they're removed for any reason at all. I do this. And if you have to make a cut in a saline implant to remove it through a small incision, you know, that cut is very evident in the photo, and you document it in your note. It's not a big deal. I'm a fairly experienced photographer, but gone are the days where I come in with a camera bag with a 35mm camera, throw my ring flash on to get flat lighting so I get a nice picture. If you try and do this with on-camera flash, you're going to get horrible pictures. But things are a lot easier these days because now we have mobile devices, and everyone's got a mobile device, and I haven't seen a nurse or technician or anyone in my OR who didn't know how to use the camera on an iPhone with exquisite expertise. So my staff take the pictures, and we get great pictures. Here's a sample taken with an iPhone showing the patch on the back, but we get the other side as well. And as you see when you blow it up, it says very clearly, style 410FF, lot number 267-9191, 290cc. No question what this implant is. But also, I like to take photos of the capsules as well. It's nice for documentation purposes. Sometimes what I'll actually do is I'll take a video. This is a patient, it's actually a smooth implant. I believe it was a patient I was putting stratus in, so I made a very generous inframammary incision, so I took everything out en bloc. I'm not a believer that you need to do en bloc resection. It was just easy. But the thing is, on the video, you can show the implant's intact. You can show how it's coming out of the capsule. And patients really, I'm doing this more and more, I'm showing patients snippets, photos and videos from their surgery on the post-op visit. They love seeing all the gross, disgusting stuff you take out of their bodies. For implant selection, I use 100% silicone gel. I think saline implants are inferior in the look and the feel and all the other characteristics. So I think with silicone gel, one of the reasons I like the Allergan, and I'm not here to tout Allergan, I just like the fact that you have 3 gel options. The more options for gel, and use whatever device it is that you're comfortable with, but for some patients, due to their preferences or my preference based on their tissue, I may want a more form-stable gel. Sometimes I want a less form-stable gel, and it's all about options to get the result that you want. This slide shows the biomechanical characteristics of the different gels of all 3 manufacturers available in this country. I don't have the data for the responsive implant. I'm not going to go into big detail about this, but what I will say is viscoelastic deformation is the most important characteristic of a gel that gives it softness. And softness is the perception of a change as you apply force to it, and you'll notice all the gels are very lacking in viscoelastic deformation. So this slide alone really indicates that all 3 manufacturers can do better and produce a better implant if they can produce a gel that's got better viscoelastic deformation. I think the implant will be far superior to what's currently available, and our patients deserve that. Photo tip of the day. If you forget everything that I talked about, I think this is really helpful. How many people here take pictures in their OR? Show of hands. How many pictures use a mobile device to take those pictures? How many people use a non-mobile device to take pictures? 3 hands, 4 hands, okay. So how many people, mobile devices belong to someone other than themselves? Okay, how many use their own mobile devices? So how often do you get a phone call, a text, or a notification that your Facebook video was just posted while you're doing surgery? It's a pain in the ass. I mean, I don't want my phone in the OR. So if you have your nurses or someone else use their phones, now patient content is on their phones. If they shoot a video and they send it to you by texting it, you lose resolution. So it becomes an organizational problem. So what I actually, and if you hook your phone up to your computer and you try and find the photos you just took, when you got 8,000 photos and your iPhone has 86 folders in it, it's impossible to find the photo. At least I find it impossible. So here's my solution. When I upgraded my iPhone from a 7 to an 11, I fixed the cracked screen, didn't put a SIM card in the 7, and now it is the world's smallest iPad. And I love it. It's got apps that control the 8 different music systems in my office, and it has a phone. And when I shoot pictures, there's one folder when I connect to my computer, so I can find my photos in 2 seconds. So it's actually been a game changer in my OR. I'll just show 2 cases really quick. Switch from MMs to SSMs. The patients are not very good about coming in for follow-up visits. After the first 1 or 2 visits, they just disappear. And this is an FF case. Going to SCMs, we went larger to make up for some asymmetry. It was an opportunity to correct a problem. And that's my whole talk. Thank you.